Can anyone hear me? All right. 1 second. We're going to try to connect these.
Amira, I can hear you.
Okay. Hi, Hinda. Okay, so folks can hear me on this side. Let's see. I can't hear you, Dr. G. It looks like I can have the video on one side or the other. What I'm thinking, my screen, like we did before. Okay, why are they saying no sound? Settings. Bear with us. We're trying to integrate these two tools together. Okay. I think I can. One second, let me go back into this meeting. System resources. Oh my goodness. Okay. Close the extra. Okay, cancel. I'm not getting any audio. Let me change.
How about now? Can you hear me now?
And now I need to check if other folks can hear us. Let me hop on there. Okay, so I think I can
All right.
share the screen with the folks with Dr. Groysman. That screen. So give me one moment.
Okay, last time. My name is Dr. Robert Groysman. I am a physician. I treat long COVID and COVID vaccine injury, POTS, MCAS, and chronic fatigue syndrome. Nothing I say on here is meant to diagnose, treat, or cure any disease. I was originally talking about blood thinners. I don't know if you guys are interested in hearing kind of my thoughts on blood thinners or not, or do you want to jump into questions and answers? Amira, when you're ready, if you want to put the screen up.
Yeah, I'm trying to pull up. My understanding is that I'm sharing the screen with you on with everyone else in the
Yes,
Zoom
when
meeting.
no, you're supposed to share your screen with the Zoom meeting on it. Remember we did this before?
Yeah, I thought. Can you refresh my memory because
You're gonna press that share screen button with the up arrow. Is the third one from the left.
Okay, I see it
And on
now.
that screen, you're going to have Zoom uploaded and logged into your account and ready to roll.
Okay.
All right. While you figure that out,
Okay.
I'm going to start talking about blood thinners.
Here we go.
Okay, guys. So
Can you see my
knowing
screen right
about
now?
the clotting cascade and platelets is basically our clotting system is fairly complicated. When there's an injury or anything that causes a clot to form, the first thing that happens are platelets get activated and they start to stick together. But that's a really unstable clot, so to speak. So what happens next is that there's a clotting cascade that occurs, and essentially it's a series of steps and is designed this way to prevent accidental activation. But once it gets to fibrinogen, that gets activated into fibrin. These fibrin strands are very sticky and they bind and kind of bundle up the platelets, forming a much more stable clot. So when we're talking about blood thinners, there's there's platelet inhibition. There's multiple different targets on platelets that can be targeted, and aspirin is one. Nonsteroidal anti-inflammatory medications are another. Steroids can reduce inflammation but don't really affect the clotting cascade. So things like Plavix also work on platelets. And what it prevents is the original aggregation of platelets. There's also anticoagulants. That's the second brand of blood thinners. And these basically prevent activation of the clotting cascade. Now, they work on different parts of the clotting cascade. And the idea, again, is to prevent or reduce the amount of fibrinogen that becomes fibrin. And lastly, we have fibrinolytics. Okay. And fibrinolytics include things like nattokinase, streptokinase, bromelain, papain, and lumbrokinase, nattokinase. So those are basically fibrinolytics. And what their job is to break apart fibrin from the platelets and the clot falls apart. Okay, so those are three things that can happen with blood thinners, so to speak. Okay, go ahead, Amira. You are okay. Yes, we got it. Awesome.
Yeah, some folks are switching from the Zoom meeting because they can't hear you. I don't know if they can hear you now, but they
I
could
don't
hear
know.
on YouTube or on Facebook.
Well, I should be good now. I figured out what the problem was, so I fixed it.
Okay, I don't know if anybody is left in the room to ask questions, so let me see how many. There are
Okay,
quite a few
so
folks that are in the meeting. So
who
there's
is
about
from Zoom? Who is from Zoom, and who is on Zoom and still can hear us?
okay, there are about 13 folks, and let's see if anybody, let me ask them. Can anyone hear me on Zoom? Okay, folks can hear me on Zoom. They just are having trouble hearing you. They said I'm clear.
Okay,
So
I don't know.
I'm wondering, might have to have one more iteration of this somehow to have
All right,
even.
well, I'm ready for questions. So if
Sure.
you want to leave the Zoom meeting
Okay.
and join us on YouTube or on Facebook or on Twitter, I mean, there's a bunch of places where you can participate.
Yeah. If they, uh, if you have, this is the problem. They can't hear what you're saying, and I don't know how to funnel the audio from Restream Studio into the Zoom meeting. There's some people are limited with what tools they have access to.
All
So
right.
it's
Well, I
kind of,
can't. I can't accommodate every single person, so
I
they're going to
understand.
have to figure out, to find a place where they can watch and ask. But I'd like to get this podcast started since we're about 15 minutes in.
Okay. All right. So if anyone has a question, um, oh, okay. People can hear you as long as you speak more clearly and slowly.
Okay, I'll do my best. Yeah, I can move the microphone closer.
That might help. Thank you, Dr. G.
All right. Well, let's start. Let's start with Becky. So Becky is asking, why is it so difficult to be tested for microclots? I am in Washington State, cannot find any testing. The testing for microclots is really only done by one or two doctors in the United States. And to me, it's not a validated test yet. And it really hasn't been completely accepted in the medical community. So, if we're talking about testing, we want to make sure that the test reflects what it's supposed to test for. And right now, that's not clear to me. What's being done under the microscope is reflecting what's actually happening inside the body. So that's why most labs have not really undertaken this test. I hope that answers your question, Becky.
Okay. I'm going to see there was one question.
We have a question from Abdul. Can we learn more about peptides and how they can help with long COVID and POTS? So there's nothing really exotic about peptides. Peptides are segments of protein that have biologic activity. Our body normally uses peptides to communicate. One of the most important peptides we have is insulin. People don't realize that insulin is a peptide. There's also oxytocin, which is another peptide that's actually a hormone, but it is a peptide. So new peptides are being discovered every day. There's over 7,000 peptides that have been identified. Not all of them can be used in humans, but there's several peptides that can help with long COVID, and not so much POTS, but with long COVID as far as cognitive ability, as far as sleep, as far as anxiety. I don't want to really go into the specific drugs on this kind of podcast, though.
Okay. I have uh, two questions. We have one person who raised their hand, Pauline Campos, who is an advocate for folks who have MCAS. Um, I'm going to unmute her and see if you can hear her question.
Hi, how are you?
Hi, Pauline. Can you hear her, Dr. G?
Yes.
Okay.
Yeah, I just wanted to say hi and to
Hi.
one clarify. I don't have long COVID. I did have COVID 3 times, but I already had MCAS diagnosed previous to that. And I remember reading a study that seemed to get buried the minute after I read it, stating that if you had MCAS prior to contracting COVID, that it actually can provide some form of quote unquote protection in reducing the longevity or the severity of the symptoms for you. But on the flip side, and at the same time, it could also, if you didn't have MCAS prior, then long COVID could result in MCAS. And so I'm wondering if you know anything about that. And the second part of that question that I have is, and forgive me for asking what might be an extremely dumb question, but at this point, long COVID to me, everything I've seen about it, all the people that I know with it, they're suffering from MCAS symptoms. So is it always going to, is it going to remain its own separate symptom, or is it like condition, or is it eventually going to merge into the spectrum of MCAS, kind of like they have the autism spectrum disorder that now includes everything, but like there's a spectrum of it. Do you know what
Sure.
I'm saying?
So let me answer your first part. MCAS is a relatively new disease or condition. It's been around for about 20 years. It was pretty rare prior to long COVID coming around, or COVID. So I have not heard or seen anything about having prior MCAS protecting you from long COVID. I don't. The second part of your question is I have not seen it associated with everybody with long COVID. It's certainly more common in people with long COVID, but I consider it a separate entity and disease. And I treat it separately from long COVID.
Okay, that makes sense. Because I do have, I guess my last question that I will ask, because I don't want to take up everyone's time, but my last question that I'll ask is for, and this is so that I can take back to my community, because I have a relatively, um, I have a decent following.
Yeah, what?
And almost all of them have others, a lot of them cast, and a lot. I think I have a few
I
people
you froze for you froze
like
for
me.
a few moments. I did not hear your
So,
question.
and for MCAS, they've got the EpiPens, they've got the H1s, they've got the H2s, they're eating low histamine, they've been told to do the whole bit,
All
but
right,
their doctor
maybe you can
refuses to
type the
diagnose
question
them
to Amira and she can tell it to me because I'm not catching
and are
what you're trying to ask.
advocating in an way.
Okay, so Pauline, Dr. G, you were breaking up a little bit, so he didn't get all your question. He asked if you could type it
I didn't
in.
hear any part of the question.
Oh, he didn't hear the question because it was a little bit breaking up.
All right, well, when she types the question, we can.
Try again. Is that better?
No, I don't want to go through the verbal again. I want to go through a written because we're having questions starting to pile up here. So, Pauline, just type out your question to Amira and she can ask it, okay?
If you could write, I think she was asking about. Yeah.
Long COVID treatment is like asking, how do you treat cancer? It's just not really, it's beyond the scope of a podcast. It really depends on what's going
With
on.
reference to MCAS,
Almost there.
All right, I'm going to take this off for the moment because I can't have her hopping on and off multiple times because it's very distracting.
okay, there. She's almost done. I think she's done typing in the question. Okay. Is there a way to help MCAS patients with long COVID to help them advocate for the MCAS if they can only get the long COVID diagnosis? So that they can get treatment for the MCAS component to their long COVID diagnosis? What could they do to advocate for themselves? As you know, you mentioned in the past, doctors really have only been recognizing it since 2018, and a lot of folks don't understand it. Some don't believe it exists. It's fairly new, a diagnosis. How does a person with long COVID who gets that diagnosis and wants to know if they're experiencing MCAS as well get treated? I mean, what would be the steps to identify it in them, like symptoms and identification?
So MCAS is mainly a clinical diagnosis. It doesn't really have a definitive blood work test or urine test to say that if you have something positive or negative that you have MCAS. So a lot of the symptoms of MCAS are related to the histamine release, but because MCAS has to do with mast cell, sorry, ah, sorry, pressing the wrong button. Because mast cell activation syndrome has to do with mast cells. There's many other components of inside mast cells that can cause various interesting effects. So a lot of it is going to be allergy based, increase in allergies, getting new allergies that you haven't had before, skin rashes, what's called dermographia, where if you draw on your skin, there's red mark there and it stays for a long time. Issues with gut is very big in MCAS. So things with upset stomach, reflux, diarrhea, nausea, that kind of stuff happens. And insomnia. Insomnia is also very big and has to do with histamine. Histamine is a neurotransmitter in addition to causing itching and pain. And in the brain, it causes you to stay awake. So it's really a clinical diagnosis, which we confirm with some lab work. But if the clinic is there, if the clinicals are there, you get the MCAS diagnosis. Okay, and then it's being treated. And there's several different ways to treat it. Okay, you can treat it with prescriptions such as antihistamines, and antihistamines come in two flavors, even though there's more than two histamine type receptors. H1 receptors mainly are in the brain and nervous system, and that's what we're talking about, the histamine kind of keeping you awake, and that's why antihistamines make you sleepy. They're also on several white blood cells as well. It helps modulate part of the immune system. H2 blockers or H2 type histamine receptors are mainly in the gut. Okay, and they control when acid is released and when your pancreas releases enzymes and things like that. It also helps release mucus. So there's a couple of things that histamine can do. Okay, so but just to answer the question, it's a clinical diagnosis.
Thank you, Dr. G.
Sure.
There is a question from Allison, I believe. Hold on, excuse me. I need to back up.
Is that on my screen or no?
From Anne on Zoom. What are
Okay.
your thoughts on cervical instability and neuro symptoms? As related to people with long COVID.
I think cervical instability is more likely to occur in conjunction with MCAS. And the reason is because mast cells contain kind of an interesting enzyme called elastase. And elastase is what it breaks down elastin. Elastin in your tissues, in your connective tissues, gives some of the stretchiness. So if you break down elastin, it becomes more floppy and easier to compress and can create something like this instability. There could also be compression of blood vessels, not just veins, but also arteries, because now the wall of the artery is less stiff, so it's more collapsible. So I don't think instability by itself would cause neurologic issues unless you're compressing a nerve or an artery or something that is creating a compromise. Um, elastin makes skin I guess more firm. It's still stretchy, but do you know how in older people their skin kind of comes off? You can take it and
Like
bring
very,
it up.
yeah.
That's from loss of elastin. Okay, and one of the biggest ways to lose elastin is smoking. um, Yeah, so the toxins in tobacco can destroy the elastin. It's part of the collagen and structure of your connective tissues. Okay.
It reminds me of EDS and EDS like
Yes,
erythema.
it mimics, and that's why some people get diagnosed with EDS.
Um, thank you. When here's a key question a lot of people wonder about. Um, when taking supplements,
All
dietary
right. Are you
supplements,
reading? Are you reading from Zoom again?
yes, from Zoom
Okay. Well,
again.
why don't we give some people from Facebook a chance first, because we've just done like 3 questions from Zoom. Okay.
Okay, so we'll alternate going forward.
Well, I think that that'll be more fair.
Sure, sure.
Um, so there was a watercress study of sorts, where I guess they broke down what kind of phytonutrients are in watercress, and they discovered actually a newer, previously undiscovered um, phenolic acid or flavonoid. Um, Watercress also has quercetin in it. So yes, you can juice with it. We don't really have a good understanding of what that particular flavonoid does yet, because it was just discovered. I mean, they just recently kind of extracted it from watercress. There's no shortage of things that we can still figure out about plants.
Yeah.
Um, it just so happens that they chose watercress to study. Um, Pretty much almost any plant, except ones that are poisonous to us, obviously, would have some beneficial value to us. Um, so I hope that helps, Facebook user.
Yeah.
Go ahead, Amira.
Okay, so we have one here. When taking medicines and supplements that need to be on an empty stomach, for example, levothyroxine, nattokinase, lumbrokinase, ceratopeptidase, how long do you really need to wait between them and food?
Well, the question is why are you taking them on an empty stomach? Is the first question, and the second question is why are you taking them in the first place? They have the capability of irritating your stomach or causing gastritis if taken on an empty stomach. And I don't really understand what the purpose would be to separate it from food. So,
I often have wondered about the levothyroxine because uh, it's cited quite a bit in the literature, well, thyroid issues, thyroiditis after COVID is frequently happening, and a lot of folks get hypothyroid. So, what I was wondering about, sometimes some medications can't be combined because, like, for example, taking magnesium with Allegra, you get a little note on, the phenylphexidine, you get a little note from the pharmacist, don't take these at the same time. You might reduce their efficiency of absorption. So I'm wondering if, having to have the thyroid medicine by itself, you need to give it a chance to get absorbed better. I don't know. Other things, like you mentioned, you need a little bit of the food to generate the enzymes and uh, I guess the environment for them to be metabolized. So we need to find out more about the how long actually. Sometimes I've heard 30 minutes. Sometimes I've heard an hour. Sometimes don't take antacids when you take magnesium. I mean, different things you find out. Usually the pharmacist has like the latest database on all of these medications and supplements. And then I'm sorry for the background. My family, my son has hypoglycemia and had to get food in the house right away. So apologize for the background life noises. Uh, I've, I found that sometimes you get better absorption of things if it's not all at once, especially people with reduced kidney function. Our kidneys process a lot. They're stressed out a lot with long COVID. And same, like a lot of our organs are undergoing a lot of clearance and inflammation. So sometimes separating things out gives a better chance. That's my understanding. I don't know if that's right or wrong, but the pharmacist would know. And then there is a department of supplements with I believe the FDA. They've got a department that focuses on supplements, and they list all the latest information about them. So dietary supplements, ODS, it's called, the Office of Dietary Supplements. So that's another resource to look at to see if they have any better info about timing. But pharmacists, I would think, would know. I'll let us go to your next question.
Okay, let's see here.
Are we at the
Let's.
top of this list or up
Yeah,
higher?
this one is from Facebook,
Okay.
and a question is how to avoid neuropathic pain. Well, neuropathic pain comes from neuropathy, and neuropathy or neuritis um, are two different things, but kind of cause the same problem. So what we're talking about here is peripheral nerves. Okay, that means outside the central nervous system. And neuritis means inflammation of the nerves, and neuropathy usually means damage to some part of the nerve that causes either pain, numbness, or tingling. Those are the top three for neuropathy or neuritis. And you really can't avoid it except um, not to have anything inside you that could be damaging or irritating your nerves. So there are certain medications that do this, and there's certain conditions that do this. The most common condition that does this is diabetes. I mean, diabetes due to the high glucose in the blood can can damage nerves, specifically the nerve endings in your feet and your hands. Feet are usually affected first because they're the furthest away, and there's more distance for the information to travel. In long COVID, I believe it's more of the neuritis variety, and I believe this is what also causes the tinnitus. Okay, I don't think there's the same damage as occurs from hearing loss. So if you're around explosives or run a concert tour and you're standing right there near the speakers, or are jackhammering, or are in a firing range all day without ear protection, that kind of cause of tinnitus is due to hearing loss, hearing damage. You're actually damaging the nerves in the inner ear. I think in long COVID, though, it's more likely to be from neuritis. I think there's nerve irritation, and the way the auditory nerve shows it is it can't show numbness, it can't show pain per se, but it shows up as tinnitus, as a tone or buzzing. So you really can't avoid it per se in long COVID. You could take some neuroprotective supplements to help reduce the effect of neuropathies. You can also take nerve stabilizers that are prescription, for instance, that can also reduce or eliminate some of the symptoms of the neuropathy or neuritis. I hope that helps.
Is some of that neuropathy and neuritis autoimmune related?
The answer is I don't know. I don't know. There hasn't been anything specific in the literature yet that I've seen. I think it's mostly from the chronic inflammation that our bodies see, and the dysregulation in the immune system.
Okay. Thank you for that. All right. Here is the next question. How Brittany asked, if you have seen long COVID, long vax use pancreatina. Okay, hold on.
Say that again, because I'm not following you.
Okay, pancytopenia.
Pancytopenia. Okay.
Yeah. Leading to possible bone marrow issues, hemoglobinopathies.
Are we talking about vaccine or are we talking about long COVID?
Either one causing pancytopenia, leading to possible bone marrow issues, hemoglobinopathies.
So let's talk about what
Tell us what.
pancytopenia.
Yeah, we need to know what that is. Thank you.
So pancytopenia affects every single white blood cell line. So if there's low hemoglobin, low red cells, it's called anemia, and if your platelets are low, it's called thrombocytopenia, right? And this affects everything, including T cells, B cells, platelets, and red blood cells, and everything in between. So rarely, some viruses are known to infect and damage the bone marrow. This is kind of where all our white blood cells are born. And if you destroy the stem cells, including the memory cells, by the way, of B cells, you can't form, or there's going to be a decrease in the amount of white cells, or you'll have no white cells. That's something we also see, for instance, after radiation therapy or some chemotherapy, where the bone marrow is irradiated or destroyed, commonly seen with leukemias. So you have to destroy the bad ones before you can introduce new ones from a bone marrow transplant. But it's not a very common finding in either long COVID or vaccine. Vaccine really shouldn't be able to do this. I would think that with COVID, it probably has an ability because it can infect white blood cells, but I don't think that it's a very common feature of COVID. I hope that answers your question. So let's take, let's see here. Who will be next? Next question here. I'm looking through the list here. So this is more of a comment. I'm assuming this refers to MCAS diagnosis. So tryptase is one of those blood enzyme tests that's often associated with anaphylaxis. That is complete immune system overreaction. Um, but we don't know what tryptase does, what its purpose is in our bodies. And really, tryptase would only be elevated for 2 to 3 hours after an anaphylactic attack. And after that, it would be back to normal. So it's not a really great test for MCAS unless you're doing it after an anaphylactic attack. And if you're having anaphylaxis, you should be in the hospital, or at least have an EpiPen available, epinephrine, because of that.
Yeah, I wanted to bring up, Pauline has mentioned being an advocate for those with MCAS, that you should have a treatment plan, like an emergency plan. I apologize for the phone. You should have a plan of procedures worked out with your doctor if you do develop anaphylactic symptoms, so that you can make it, to get treatment. You should have, Pauline, if you could text what that plan was called, like a emergency plan. Yeah. I can't tell you how many people that has helped who didn't know about it, asking for it, actually. Not. I'm so glad you mentioned about the EpiPen. A lot of people don't know to even have one. And I had lost a classmate from high school to a bee sting, wasp sting. She was a mom of several children, and then got stung, and then was gone, and never knew she needed an EpiPen or anything. Okay, so they call it a rescue plan. So Pauline has brought a lot of information on the TikTok platform about having a rescue plan and knowing what to do if you're stuck out in the car, you're grocery shopping, you have an allergic response. Do you have on you what you need to manage so you can connect with your doctor and get help. You know, make it to 911.
Right. Well, anaphylaxis comes on fast. And the two things that are, I guess, the danger part of anaphylaxis is your throat closing up because of bronchoconstriction. Okay, so your airways completely close up, you can't breathe. And the second, and that's one that can kill you. And the second is cardiovascular collapse because of vasodilatation. So all your blood vessels dilate and your blood pressure drops very precipitously. And that's where epinephrine comes in for both of those things. You may not have much time to call 911 or your doctor. The process of anaphylaxis is very rapid. And hopefully you've had signs that you're at risk for anaphylaxis. Now, the ones that we normally deal with are not MCAS related, are food allergy related or bee sting related. So things like latex, bee stings, shellfish, and peanuts are ones that can cause anaphylaxis. There's usually plenty of warnings beforehand, so you know. And you get yourself an EpiPen, and it stays with you all the time. Doesn't matter where you are. You're in a car, you're in a store, you're at a party, you go on vacation. That EpiPen comes with you, always and forever.
Yeah.
And MCAS is no different if you are subject to anaphylaxis.
Gotcha. And maybe know how to use it, because sometimes folks have been told, go look on YouTube how to use it. You know, when they've asked their provider, how do I, inject it? It's a different looking pen than I knew from before. So you need to know how to use the one that I would say maybe ask the pharmacist when they give it to you to open and show you how to use it, or have the doctor show you
Yeah.
how to use
It
it.
comes as an auto injector,
Yeah.
and it's already pre-programmed for whatever dose you need.
Right.
Let's talk about POTS.
Okay.
Is tachycardia with long COVID greater than 30 beats per minute on standing different than POTS? No, that's basically the definition of POTS. POTS is postural orthostatic tachycardia syndrome. So the idea is to get a baseline supine, which is laying flat parallel to the floor, for about 10 minutes, checking what your blood pressure and heart rate are, and then standing up. I mean, yes, traditionally it's done with a tilt test so that you're not moving your legs or arms at all. But this is something you can even do at home if you're leaning against a wall, for instance. But the idea is to get you into an upright position and checking your heart rate and blood pressure, okay, at several intervals. What makes the diagnosis of POTS is having the 30 or more beats per minute increase at the 10-minute mark. So just about everybody is going to have a heart rate increase in the beginning. That's what's supposed to happen. That's what happens as a compensatory mechanism until your blood vessels in your legs constrict and force more blood volume into your heart. But with POTS, that mechanism is delayed or impaired. So you don't really contract those blood vessels, and only a partial amount of blood comes up to your heart to increase the blood volume. Once the blood volume increases, the heart rate goes back down. In POTS, that doesn't happen. Now, why is it important to check the blood pressure? Well, if the blood pressure drops and stays low or you pass out, that could be a diagnosis of orthostatic hypotension. And that's a more severe form of POTS. Here, the blood vessels are not contracting at all. So your heart does not see any additional volume, and that's why your blood pressure drops. Both can cause orthostasis, which means dizziness or vertigo or passing out on standing. In POTS, that happens because the heart rate gets to such a high point that it's no longer able to pump blood effectively. In orthostatic hypotension, that happens because there's not enough blood volume being delivered from the lower extremities. Everything pools in your legs. Okay? So that's pretty much what POTS is. I hope that answers your question, Facebook user.
We have
You're up.
a question about related to muscle wasting and what can be done to prevent this while also dealing with post-exertional malaise. And for those that don't know what post-exertional malaise, could you start by explaining that, Dr. G?
Sure. So let's talk about the three things that are kind of related but mean different things. Fatigue. Fatigue is a sense of just being tired and not being able to do much. It has nothing to do with weakness. It's just not having the energy to get up and do anything. Then you have exercise intolerance, and that's just inability to exercise because you're not able to raise your heart rate and tolerate any form of aerobic activity. That includes walking, weightlifting, any type of running, things like that. Bike. Post-exertional malaise is a little different. Post-exertional malaise is basically feeling tired and sick after exercise. So you're able to exercise or do something, even something minor, something like walking down the kitchen, and your body kind of pays for it in a couple hours or even a day or two. And basically, it's a severe form of fatigue and feeling sick, feeling like you just can't do anything. That's what post-exertional malaise is. So let's get to kind of some causes here. I believe that the post-exertional malaise comes from mostly mitochondrial dysfunction. We have seen several different studies come out talking about abnormal mitochondria in muscles. And I believe that most of the dysfunction is functional here. That is, there's some abnormal protein in the mitochondria preventing energy generation. This usually comes in the form of interrupting electron transport cycle that happens in the mitochondria. So the reason that you breathe and you take in oxygen is for the mitochondria, for no other reason. The oxygen is used only by the mitochondria to basically burn the fuel, which is glucose or amino acids or fatty acids, and it converts it into ATP, which is our main energy currency. If you interrupt that cycle, you interrupt aerobic metabolism, and your body relies more on anaerobic metabolism, which yields a whopping 2 ATP per glucose molecule versus 32. So you have a much lower energy reserve. And I think because of that, your body pays for it if you do any kind of activity. I'm not going to go into how to manage mitochondrial dysfunction here. I believe I've posted some information in the Facebook group about that. It's more than one supplement and medication that can do that.
Thank you.
You're up?
Okay.
Or am I up?
You're up, but
I'm
I
up.
have another one ready.
Okay.
Can let's see, burning mouth be caused by long COVID? What is the cause of it? If so, how do you treat it? Thanks.
We don't know the cause of it. It may be part of Sjogren's, which is an autoimmune condition, or it may be something completely unrelated. There's no surefire or definitive treatment for burning mouth. I typically use rinses and kind of oral type treatments for it that hopefully would reduce some of the burning. But there's really nothing specific or definitive for that treatment, unfortunately.
I have my theories all related to the gut microbiome. As you know, I'm always looking at it from our commensal flora or gut microbiome, and the whole enteric cavity is affected by post-COVID and long vax. It's all affected, and the inflammation can happen and alter the flora in the oral cavity, and things that, for example, let's say some of the viruses can show up and cause irritation and inflammation in the mouth. Some, people can have more dental decay. The species are changing that are in the mouth, and the acidity changes, the whole environment changes, and you see there's a lot of oral uh, dentists that are studying the oral microbiome to figure out what's happening. They're trying to do genomic studies to see what's happening in the process. Different kinds, like you mentioned, some magic mouthwash, different kind of mouthwashes that are specific for what might be happening in that person. And usually it's a compounding doctor or pharmacist, excuse me, that mixes it up. And it's something you swish and swirl. It happens to a lot of folks with some rheumatological conditions. They endure, and some folks with cancers who go through chemotherapy um, end up with some of these symptoms, and they have like a combination of things, everything from Benadryl, Maalox, viscous lidocaine liquid. Some have antibiotics in it, some have antifungals. They're all designed. So I think they've even had Maalox in one of them, or Pepto Bismol. They've had like different combinations in them to address what's happening in that person's mouth, because it can get so painful that also interferes with their ability to get nutrition in and further exacerbates the problem. So,
I have seen a couple of different presentations. One is involving the tongue only, where the
okay.
tongue hurts and burns. Another is involving the gums. And the third is involving kind of the sides, the cheek area.
Yeah.
I'm not sure if they're all from the same cause or not, or the variations um, on kind of the same theme or not.
Yeah. They may each require their own different combination of treatment. So,
But that one is particularly difficult to treat.
yeah.
I'll admit that that one is difficult, even with even with mouthwashes and things like that.
Yeah. Okay. Are you ready for one from the Facebook groups?
I'm looking. I'm looking.
Okay. There's
Guys, if you
quite a
can just keep your questions to like 5 lines or less, that'd be great, because it's very hard to read, an entire paragraph or two. If you put that in, and I'm just not able to read those. I'm trying to see what. Okay, Melinda is asking about the carnivore diet. Let me explain my stance on fad diets in general. I'm not a big fan of purposely restricting to a particular food, or eliminating carbs or eliminating fats or eliminating proteins or any variation of those. People are having issues with malabsorption as is, and by restricting your diet even further for no reason, you're just putting more stress on your body, I believe, and making your mitochondria work harder to try to extract energy from something that it prefers, which is glucose. Okay, your body likes glucose, it prefers glucose. Glucose is number one for your body. It's the easiest thing to get into the Krebs cycle and produce ATP. It has to work a little harder to convert protein and to convert fat into a substance called pyruvate, um, before it's able to enter into the Krebs cycle. Now, what's cool is that amino acids can enter, I guess, into different parts of the Krebs cycle. They don't have to start at the beginning, but there's still work involved. There's more work involved. We're not carnivores. We're omnivores. Plants and greens and fruits and vegetables are extremely important for our diet. Aside from all the antioxidants, the phenolic acids, the flavonoids, um, all the phytochemicals or substances that are very helpful for our body, not just for antioxidants, not just for anti-inflammatory, antifungal, antibacterial, antiviral, hepatoprotective, neuroprotective, cardioprotective, pulmonary protective. I mean, you're basically cutting out the most important part of our diet, to eat meat and fat and meat. Meat is oxidative. Okay, in which way? Fat is very oxidative. It really puts a lot of strain and stress on the mitochondria to break down fat, and it tends to be less efficient at generating energy from it. Yes, fat is more calorically dense, absolutely, but it generates a lot of oxidative, radical species, and stresses your mitochondria further. So my advice is don't choose any fad diets, and that includes keto diet, carnivore diet, and whatever else. I mean, I'm sure there's hundreds of diets out there. I put people on low histamine diets sometimes if I think that histamine is an issue, but I don't want to. I don't think these diets are really useful, and I don't want to keep people on these kind of fad diets for very long. Okay, we're creatures of the omnivore, which means we're supposed to get a little bit of everything. If you're a wolf or a cat and you're an obligate carnivore, fine. You're evolved to a point where you can live off meat, but we're not like that. We need our greens, we need our fruits, all the vitamins that we need to take come from fruit. Are you going to be supplementing all these things through pills and capsules? That doesn't make any sense. I would steer clear of the carnivore diet for this. And I think if nothing else, it's going to increase inflammation, not decrease it.
I would also mention, when you look at a patient, you really have to look at treating both their gut tissue health and their gut microbiome. You have to eat to repair both of them and feed the proper amount of fiber in terms of, fresh fruits and vegetables that don't trigger inflammation in the person, that will help promote the growth of the commensal or gut-friendly bacteria that will get the nutrients out. Because it's like a battle. You have to minimize inflammation in the gut, and as well as support the rebuilding of a healthy microbiome so that your immune system is supported. That's my theory, my
Yep.
experience.
So let's talk about fiber. Fiber does not come from any animal. Any animal byproduct or animal meat or any product coming from an animal. It has to come from a plant. Fiber is the main food source of your microbiome. Now we can't break down fiber. We don't have the ability to break those bonds, but the microbiome bacteria can, and that acts as a food source for them. Even though it's an anaerobic environment, because there's no air or oxygen in there, or really not much, and that's what they use to generate ATP, and it keeps them healthy. So yes, it also helps move food along, because some of it is not digested, which is kind of what we want. Um, but I can't imagine what kind of stool pattern you'd get from a carnivore diet. Um, but it's not a healthy one.
Okay. I have a question from Sandra in Zoom. How long to regain a sense of taste and smell? Or, what can be done and how long to regain?
That's the $1,000,000 question, isn't it? What we've learned is if you have complete loss of taste and smell, we're talking about anosmia and ageusia. Um, and the same thing is true with parosmia and dysgeusia, which is abnormal smell and taste. So earlier, the better. The longer your body sits with this, the more difficult it becomes to treat. There's only a few things that work for smell and taste in as a result of long COVID. The biggest one is going to be the stellate ganglion procedure that I do. Nicotine as well in the form of a patch has been shown to work. Vagus nerve stimulation can help. And some people have recovered from intermittent fasting. There's also some other less successful but still worth trying methods. One is insulin, nasal spray. Oxytocin has also been used in one study, not associated with long COVID, but nevertheless, it's been shown to help with reestablishing smell and taste for anosmia.
I heard somebody mention acupuncture helped them. I'm not
I'm
sure.
not going to go down that line. I do think
Yeah.
acupuncture has certain benefits, but I don't really believe that it has a capacity or a way to really restore smell and taste, no more than I think that the flick that was created by the chiropractor or the head slap invented by a different chiropractor would restore smell and taste. There's just really no mechanism behind it. Um, I mean, I respect acupuncture for what it can do,
And what about the
but
smell retraining? Has that
I'm sorry.
the smell retraining? We'd seen earlier during the pandemic, some groups had developed some kits for smell retraining, like stimulating, I guess, the sense of smell by practicing smelling things, particular uh, odors. Um, they had these like little kits they put together. It was maybe it was a parosmia nonprofit group or something like that that had these smell retraining. I guess not much came out of it because we're not talking about it. But
Smell retraining has not really been shown to help with the type of loss or abnormality associated with long COVID. It is a
okay.
staple for ENT doctors for other
Uh-huh.
causes of loss of smell, such as trauma.
Okay.
Um, but it has not been shown to be helpful alone in long COVID.
Okay. You have a ton of questions over here.
I know I'm
What?
trying to go through the questions
Yeah.
and
While you look
kind
at
of
that, I
go.
want to ask. Yeah, while you look at the next question, I want to ask folks to put in the chat how they heard about our um, uh, outreach and educational Zoom meeting. If you could post it in the chat, that would be great. Let us know. Obviously, it's if you're in Facebook, you know, we're familiar. If you're in Zoom, if you could let us know, or if you're in TikTok, just let us know how you heard about it. Did you hear about it on? We want to know the best ways to reach folks to let them know about these events and help educate community. Dr. Groysman does this regularly every 2 weeks to help
Oh,
us educate.
Remy's on.
Yeah, Remy's here. Welcome, Remy.
I have her volume up, so you should be able to hear her.
Hey guys,
Hi,
Hey,
Remy. Welcome.
thank you.
Remy is an advocate and a long haul COVID warrior who has survived several bouts with COVID, and she's dealt with a lot in the past few years. So let's um, let her share some new things that she's heard
All
about.
right, before she does that, let me just say one thing about tinnitus.
Sure.
I've already kind
Okay.
of explained my stance on tinnitus. I still see a couple of people asking a few times about tinnitus. Um, as I said, I think it's a neuropathic cause, and my treatment focuses on the neuropathic cause. Um, Go ahead, Remy.
To uh, piggyback off of what you were saying, I I have tinnitus, and I totally agree with what you're saying. My doctor, I kept going to the ENTs, and they kept telling me your hearing's fine. There's nothing wrong with your hearing. There's no hearing loss, and none of the doctors could tell me what was going on. And until I came across a doctor that kind of surprised me, and he put it together when I noticed my symptoms would worsen with certain medications, and he said, hey, that tells me that this is neurological. And I was like, how does something neurological, how can you hear it in your ears? And then he explained about the nerves that are like hairs, or something about the brain and the ears, and this is why you can hear the tinnitus. So it's not from the ears, it's neurological. So I happened to jump in at the right time, but I didn't know that was a thing.
Yeah, it's a
um
thing.
wow. So
And
how do
yes,
you
some medications can make it worse. Absolutely. I was going to make a list of the medications that make tinnitus worse, but then I got sidetracked with
okay.
other things and haven't had a chance to sit down and actually record the video. But most people are probably not taking these medications. It's just it could they potentially could cause problems.
Yeah. Or sometimes it'll, like for me, it would temporarily flare up the tinnitus, and sometimes you get lucky and it would just calm down after you stop the medications. But for the most part, everyone, I guess, is different, and it just depends. Certain medications will make it louder, and then I just tend to stay away from that class of medication. But
So let's talk about tinnitus a little bit more, I guess. So there's several different kinds of tinnitus. Some of them are like a constant tone or buzzing sensation. And some people describe, I saw somebody asked about this here, about pulsatile. So if we're talking about something that's like a whoosh whoosh, like when you have water in your ears or underwater, or you close your ears and you hear that whoosh whoosh sound, that's vascular.
oh wow.
That is tinnitus per se, but that cause is very different from the tone. So that could be a blood vessel issue. There could be an artery that's too close or has been compromised because it's not as stiff anymore, and it's too close to the inner ear, and you're hearing basically the blood flow in the artery. That's a little bit more difficult to obviously treat than a constant tone or buzzing that's neuropathic. Okay. So I just wanted to clarify that. I don't think there's really any supplement per se, including zinc, Andrea, that that would treat tinnitus, neuropathy, or the issues with neuropathy that way. Vagus nerve stimulation has been helpful for many. However, there's a few that report that their tinnitus temporarily gets worse with it. And I have successfully treated many with a stellate ganglion block for their tinnitus. Now, I should preface that not everybody had relief. Some people did, some people didn't, but they usually weren't coming to me specifically with the tinnitus. It was other things. And tinnitus was just, by the way, hey, my tinnitus is gone. There was one gentleman who came to see me, a young fellow who was a musician, and he could not play. He couldn't work. He couldn't play his instrument, and he couldn't do anything because of the constant ringing in his ear. And it was only one ear, and it was 80% or more reduced post block. So that really kind of reinforces the whole neuropathic thing. Because you can't reverse damage with a block, because things don't heal in 5 minutes, right? Somebody asked about vagus nerve stimulation, right? And healing. So parasympathetic tone is important for healing. The rest, digest, repair, okay? So if your body is in sympathetic overdrive, sympathetic tone, fight or flight, however you want to call it, your parasympathetic isn't really, in the driver's seat. It's in the passenger shotgun, and your body is not going to focus on healing. It's not going to focus on digestion, and it's not going to focus on repair when your body is in the state of alert. Fight or flight, right? So you're not going to sleep well. Why? Because your body thinks it's in danger, and you're not going to repair because your body thinks it's in danger, and nothing really happens with replacement, turnover. So yes, that's the reason we age. We're aging more rapidly with long COVID, absolutely, because your body is stuck in fight a good portion, if not 24/7. And your body normally spends most of the night that's during deep sleep repairing everything, replacing cells, repairing cells, healing tissue. I don't know if you ever noticed, you get a cut and you're up all day and the cut's still there, and in the morning the cut is mostly healed. Well, that's because of the deep sleep. You're healing at night. You're not healing during the day when you're active and your sympathetic is working. But at night, when the parasympathetic is almost 100% in charge, it's focusing on healing. It is closing up that wound. It is clearing out any infection. It is growing additional skin cells and connective tissue in the skin rapidly during that nighttime period. And when you wake up, it looks a lot better than when you went to sleep. Even though you were up for at least 12 hours during the day, looking at that cut, and it looked the same to you. Nothing changed. I'm talking about paper cuts. You know what I'm talking about? They're annoying. So vagus nerve stimulation is going to help activate the parasympathetic nervous system, even if it's for a short time. It's still better than zero, which a lot of people with long COVID are enduring. I mean, you're basically running that engine in first gear at 60 miles an hour. Yeah, it's going to wear out a little bit. That's the aging part. Okay. And you can't replace cells. You can't heal. You can't regenerate. Regenerative medicine, right? You can't regenerate because your body only does that under parasympathetic control. Okay. And since you're stuck in fight-flight mode, that's why your immune system is also overactive. Parasympathetic tells the immune system, calm down, relax, everything is fine. You know, there's no infection going on, there's nothing happening, relax. Inflammation, you can have a seat. But sympathetic is ready to go, you know. Everything, not just anxiety, not just having a ton of energy, at least in the short term, in the beginning, until you start to wear out. But it also riles up the immune system too. It tells all the cells, you know, hey, something's happening. Get active. But anyway, so yes, vagus nerve stimulation does help with pretty much healing anything. Okay, it's been used successfully in ulcerative colitis. It's been used in rheumatoid arthritis. It's used for seizures, seizures that don't respond to anything else, don't respond to medication, don't respond to anything. It's been used for arrhythmias. And it's shown to help with many of the autoimmune conditions as well. Again, it helps quiet down the immune response. All right, you're up.
Okay.
Amira, what did you want me to
Jenny
share?
has a question.
Okay.
Jenny has a question that somehow we
Sure.
missed. Jenny, could you put your question in the chat? She's having she has an issue daily. It's affecting her body terribly. She's I need to locate her message. So
Yeah, so far that information doesn't really tell me anything.
Yeah, I need to see it. Do you want to share with us, Remy, about a lot of folks?
The
Not
information we
everybody
talked
has a
about?
family nearby to help them, and you learned of some things that.
Yes. I just wanted to share some information
Sure.
that may be helpful to people that may need like a caregiver, and how to make someone in your home a caregiver. And I also found, I don't know if there's other people here trying to look for work, but it's hard because of your limitations. There is something called the DARS program. It is DARS. I think it stands for something rehabilitative services, but you put in your state, and you put in, your city, and it'll find a DARS program in your area. If you call them, they will assign you a caseworker. You tell them your limitations. They're going to have you sign a release with whoever you want them to get a hold of so they can qualify you. It could be, you could qualify for mental health. You can qualify for pretty much it's not that hard. If you have some type of ailment that's bothering you, even if you have had an IEP, it will qualify you. You can get your GED. If you want to go to college or you want to go to school, they will help you with getting financial aid. If you don't qualify for financial aid, they will pay and fully fund your college, trade school education. If you are not interested in going back to school, they can help you find a job and a job with your accommodations. And if you want to start your own business, you go before. Um, I don't know if everyone is familiar with the Shark Tank. You know how Shark Tank, you present like an idea before someone, and they'll tell you if they'll fund it or not. Well, it's kind of similar, because when I was starting my own business, I went before this guy. I told him, I showed him my talent and my idea. He loved it, and what they do is they will fund your business, and whatever materials you have to add it up. You give them a presentation, and if they approve it, then they will support your business and they will fund it for you. And again, it's called the DARS program. It's DARS. It does stand for something. Um, I
I
don't
think
know if
it's
it's available in every state.
disability and rehabilitation services.
Yes, correct.
Either that or
Yeah.
Department of Adult Rehabilitation Services, something like that.
Yes. So I'm in the state of Virginia, so they do offer it in Virginia. I don't know about other states. I know that you would have to put in like DARS and your state to see it. I don't know about Texas, but that's a possibility. I'm not sure.
Yeah, I'm not sure about DARS.
I don't know about Texas, but I do know in Virginia, this is what they offered me. But it's called the DARS program, and it says it's for aging and rehabilitative services. Then there is another thing. Um, yeah, you're welcome. There is one more other thing I wanted to share. If any of you need some type of help at home and you don't qualify, let's say for Social Security, um, if you call your local Department of Social Services, not Social Security, but you call your local Department of Social Services, request to make an appointment to have a U as an umbrella, A as an apple, I for igloo. Request a UAI appointment. And what that does is it'll start the process by having a nurse and I believe it's a social worker. They will come to your home. They will interview you. In my case, I had a template that I created. It had all my medications, it had my chief complaints, all my doctors, all my specialists. I highly suggest being prepared for the interview. I had photos of my disability. Um, so I presented all of that to the nurse while the social worker asked me about my limitations. And then after that interview, once you get approved, you are allowed to choose someone in your home. You can, depending on the interview, based off your answers, they would either allow you to be your own boss, or you can have someone on the outside that would do it for you. In my case, they found me, able to make decisions for myself, and so my daughter is now my full-time caregiver. I don't know about any other states, but I know here in the state of Virginia, they start the person at $16.45 an hour, and based off your disability, Medicaid then decides. I also qualified for something called Medicaid, long-term Medicaid. So they will qualify you for that. So I qualified for long-term Medicaid, which offers you more than regular Medicaid. And my daughter is now my caregiver, and she gets paid to be my caregiver. Um, so that's the beginning of that. It is a very long process, but I wanted to share a little bit of that information because I thought it was the end of the world when I was like, oh my God, I can't qualify for Social Security. Oh my God, I'm married and I don't qualify for things because I'm married. However, I got into contact with the right people, and luckily someone cared enough to say, hey, there's a way around that. And I'm like, really? And they said it doesn't matter if you're married, if you're disabled, call your local Department of Social Services. And they didn't, it didn't matter what my husband made. And now I'm on
How
long-term Medicaid.
how long did it take once you called the social services to go through that process to get the help? Because there are quite a few folks, some who are
Yes.
single, who need help at home. They're like really struggling.
Oh wow, $10 an hour there. Oh wow, okay. Well, so it didn't take really long. They told me it was going to take a few weeks before you get approved. I got lucky, and within a week, I got a phone call, and they were really nice. I loved the two people that came to my house. I know that may not be the case everywhere, but I got very lucky that the caseworker was amazing and the nurse was very, you're welcome, was very friendly. And just them seeing the photographs, my records, like I willingly gave all these things. And when they saw like the evidence, the nurse didn't even question me. She was like, look, this is enough. Can I take this with me? And within a week, I got a letter stating that I was approved. And then after that, you get assigned like different people as you go through the process because it's not just one person. You go from like case manager to case manager as you graduate. So once social services does that part, then they transfer you over, and then they allow you to pick an agency. Um so I really love that you have that freedom. So you get to pick the agency, because although you're hiring a family member, your family member has to work for an agency. Um, photographs, photographs. You don't have to give the photographs because she's like, what kind of photographs? Pretty much of my symptoms. So I have a mast cell disorder. So when I eat certain foods or I come into contact with certain things, I'll have like eye swelling, lip swelling. I go into anaphylaxis easily, mucus production, you know, when I being
Rashes,
underweight, bruises, all kinds of things that just showed, rashes. So that's what I mean. So you don't have to. I just was very organized, and I was really nervous, and I was trying to avoid answering a lot of questions. I just said, "Hey, here's everything on paper." And the lady was like, "Hey, can I take this with me?" And they didn't even, it just made it easier. So you don't have to do this. You can answer their questions. I was just nervous and said, "Here you go."
Remy is sharing that with all of us, so she's gonna get it to me, and I can share it with all the group. And she's gonna make a video describing a little more details
Yeah,
about it.
I'm almost at the end of this process. It is tricky. I am going to make a video on TikTok where it's just more in detail because I have been recording every step because of my brain fog. It's very hard to keep track of everything. So I've been like recording every interview and like, oh, so I need to talk to this person and this step and this step. Because there's a lot of us out there that we're fighting social security and you don't get help or approved. I mean, I know someone that it took them 7 years. Who has 7 years? With this experience, it took me a few months. I was approved in a week, and everything went pretty fast. And my daughter is going to get paid very soon. The other thing that's cool about it is if you have a a family member, they don't pay them right away. It kind of works kind of like Social Security. Once you're approved, from the time you're approved until everything goes through, they're going to give you all that back pay to that family member. And on top of the 1645, they also give you respite care. And what's cool about the respite care is my
Remy,
I
let me interrupt you for 1 second. I
Yep,
have a hard stop at 5. Okay.
got you. So, well, I'm almost at the end. Respite care is pretty much if that person wants a break, they will pay someone else to step in. Or if you don't use it on somebody else, that person can use it as overtime, pretty much. So, but if you guys have any questions, I don't know how I'm mostly on TikTok. I don't know, I don't have any like open social media on Facebook, but I am Remy Doll on TikTok if you guys want to friend me and have questions. Or you can get a hold of Amira.
I'll get hold of Remy.
Yeah. And that's all I wanted to share, just to kind of help out.
Thank you, Remy.
You're welcome.
Appreciate you. So I have a question now in the Zoom about liver.
Yes.
Nigel, actually, there were two questions. I have to get back to Jean after this, but my liver is being damaged by long COVID. How can I help the liver? I had a good liver LFT count prior to COVID, and it rapidly increased in the last 7 months. I now have liver fibrosis, F2 damage.
So, I mean, liver can be damaged from many different reasons. For instance, Epstein-Barr virus can attack the liver. So I'm not really sure exactly why you're having the problem with the liver. There's also autoimmune reasons. There's autoimmune hepatitis. There's infectious hepatitis, and then there's the excretory or secretory part of the liver. Making the bile. If that gets backed up, that can cause problems with the liver. So, without knowing more information, I can't really answer. Um, what to do about the liver in general. Um, you want to also review your medication list or your supplement list. Make sure you're not taking anything that's further stressing your liver, and that includes substances like alcohol and anything that has Tylenol in it. Both of those are particularly stressful on the liver. That's all I got for the liver with the information I have.
Yeah. I do know that SARS-CoV-2, as well as other studies and long vax, have shown in other animals, not in human beings, but um, if there are ACE2 receptors on liver cells, epithelial cells, and liver. There have been case studies where a lot of kids were getting some hepatitis after COVID uh, infection. That was the only thing that was showing in them was, well, technically diarrhea and hepatitis of their liver. They weren't showing the typical other symptoms that adults were showing in their lungs and taste and smell and things like that. Um, so there's a lot more that needs to be learned. But everything that I have read and studied, you work on controlling systemic inflammation and you support your gut health, your gut microbiome, all the signaling, because we have not only the gut brain immune axis, we have a gut liver axis, gut lung axis, gut heart, gut kidney. and all of
Liver
this,
and
yeah,
brain.
and brain. So all of this communication going on with the help of our gut microbiome.
Yeah, I'm not really going into the microbiome in the gut. Yes, I do
There's a lot
think
of
that
signaling
it's a
happening,
big.
and not to between the. I'm
I
sorry,
do think that
you broke up.
I do think that the gut is responsible for some of the mechanisms for causing long COVID. However, I've discussed that in a few other podcasts in great detail, so I don't really want to go again into the microbiome and the gut. Um, I want to address some new issues and new questions. I mean, it's obviously an issue. It's obviously something we should be looking at and treating, and I do in my clinic.
Yeah.
There's a question by Angela. Can long COVID cause gastroparesis? Yes, I've seen it in quite a few patients. And the most common cause of gastroparesis outside of long COVID is diabetes. And how does diabetes cause gastroparesis? Well, it damages the autonomic nervous system, the vagus nerve. And the vagus nerve is responsible, along with the plexuses in the gut, to move food down from the time you swallow, down your esophagus, open valves, or open sphincters, I should say, in between the esophagus and your stomach, and then start digestion. All of that is synchronized, and you don't have to think about it. And there's really nothing you can do to, cause increase the digestive mechanisms or anything that happens all behind the scenes. That's controlled by the vagus nerve. And since there is damage or irritation of the vagus, and we know it's thickened in people with long COVID, it's no surprise that we're seeing symptoms like gastroparesis, like diarrhea, like hoarseness or trouble swallowing, painful swallowing, changes in the voice. All that's responsible, the vagus nerve. That's what's responsible in those cases. I hope that answers your question, Angela. Let me talk about low dose naltrexone real quick. Um, it works by calming down microglial cells, which are support cells in the central nervous system. Okay, it also helps with analgesia or pain, not necessarily related to the central nervous system, but um, throughout the body. That was another question I had by Facebook users, so I figured I'd go ahead and answer it. So that's the mechanism. Go ahead, Amira or Remy, if you guys got a question.
Jenny was asking about any understanding about is there shedding of the vaccine and how it affects her body by accelerating her long COVID symptoms for days or weeks. So
What accelerates it?
I don't. She says folks around her that have been vaccinated, she's concerned about shedding of the vaccine. She seems that people who've been vaccinated who are around her inflame her symptoms more. And I would have to ask her, how is she handling this? How is she staying by herself mostly? Because it could be anything triggering her symptoms. How does she know that it's that? I would need more data.
Well, if you take the vaccine companies at their word, and you're either getting the mRNA enclosed in a phospholipid capsid, or you're getting the protein, such as a piece of spike, like a more traditional one, like Janssen does. There's nothing alive in those vaccines. Now, the mRNA only codes for a piece of the spike protein or the spike protein. It can't replicate a virus. It can't replicate on its own. It can only produce protein. And the one with the spike protein, like Janssen, um, you're forming antibodies to the spike or segments of the spike. So in order to shed something, you need to have it replicate. And shedding spike, it's not alive. Well, technically viruses aren't alive either, true. But I know there's been kind of a lot of talk about this. Even something like prions require ingestion. So there's been no evidence of shedding of spike protein in breathing or coughing that I'm aware of. So if it's shedding in your stool, well, how are you sharing that with people in the same room with you? Things don't quite make sense. If it turns out to be positive in coughing, sneezing, talking, breathing, then it would be very similar to a prion, yes. But just because you're exhaling it, and that again, we're talking about hypothetically here. None of this has ever been shown or documented. Okay, it's very important. We're just talking hypothetical here. You'd have to also show that it would be incorporated into the next person and cause harm. So there's a lot of steps that need to happen. It would need to make its way into the lungs and, or into saliva and be expelled that way. And then you have to show that it's being contagious, so to speak, virulent. And so far, we don't have any evidence of this.
A lot of viruses are unstable out of their host. So I don't know how stable it would be outside.
Well, proteins in general are not going to be very stable outside the body, but nevertheless, it's a possibility to explain why some people feel like they have a reaction for people who have been vaccinated and or had COVID before. So this has not been demonstrated yet by anyone. It should be relatively easy to test. Basically collect a specimen from the nose or mouth and analyze to see if it does have spike protein in there.
Yeah.
And then collect air samples and see if spike protein is still in one piece and airborne. So, there's ways to test for it. Somebody's asking about a questionnaire to check the list of symptoms tied to long COVID. Let's see, I don't even know where this is. We're so behind on questions. We're obviously not going to be able to get to everything. The questionnaire, I have a questionnaire on covidinstitute.org. On the left-hand side, it's basically the patient paperwork, and that's what I use to help diagnose and come up with treatments for patients who come to see me.
Yeah, I wanted to bring up one thing. People have had so much medical PTSD, and they've struggled to explain to other physicians that don't have the same understanding of long COVID and long vax that you do. And some of, are worried that will we be able to tell our story in 45 minutes? And those that have followed you and have been at all of your educational Zoom meetings and podcasts know that you can ask the right questions to get to the heart of the matter and come up with a plan to help folks, develop a plan within their means to help them recover some are worried that is 45 minutes enough to could you for a person if they're trying, a lot of people are out of state and they're desperate to want to get to a specialist
Right.
like you, if you could just brief overview of the process
Well,
and what they would.
I usually just listen in the beginning. Some people start, way from the beginning. But what I'm really interested is to know what's going on now. Not necessarily the entire history, because it evolves and changes over time. And then I'll ask pointed questions to determine if I think it's one or the other cause, and I'll either rule in a cause or eliminate it. And then we'll decide on what additional tests they need if they don't have the test results already. And these are specific tests. It's not a kitchen sink approach. We're not doing 200 tests. We're doing between 2 and 5 tests or around there, to basically confirm my suspicion or rule it out. And then we would select supplements and/or medications, depending on what's going on. I mean, that's the general flow of things. Sometimes I need more information, like HRV, um, or see if they've tried certain treatments and therapies. I mean, yes, 45 minutes is a short time, but I mean, from my standpoint, I'm not doing most of the talking. I'm doing a lot of listening.
Gotcha. So
But
they fill out a form and you get some preliminary information
yes,
to begin. Okay, so that would
yeah.
be
At
like
this
step.
point, at this point, I'm more than 3 weeks out, for appointments.
Wow.
So,
Yeah.
we're
So
trying to
thank
accommodate everybody, but talking for 45 minutes at a time, going 45 minutes. So, I don't have a lot of breaks in between.
and you do treat people from other countries and do offer translation services and can work with other doctors overseas. You can help the patient come up with a plan. So folks should be able to know that because we get a lot of viewers from overseas, Europe, New Zealand, Australia, the
Well, those
European.
are all English speaking, but we're able to translate live, with a live translator, in 240 different languages. So, I
Wow.
mean, not every language, but pretty much everything under the sun that you can think of, except maybe some weird dialect from a small village.
Yeah.
Maybe we won't have that, but um,
Yeah.
just about everything else we can do.
So you get one of the things that I appreciate about Dr. Groysman is his dedication to equal access to information, to the tools that can help you. Um, he he goes above and beyond what a lot of healthcare workers are providing these days. So and dedicates a lot of time because for every one of these meetings, he's doing a lot of research and then also responding to a lot of technical questions and researching. And I want to thank you again for donating your time. Uh, he always volunteers this time, folks, so we really appreciate it. Thank you, Dr. Groysman.
We still have
And
a few more minutes. Let me look and see if. I mean, I can't answer. I really can't answer. General questions. Is tips to reduce chronic inflammation. Well, How do you reduce chronic inflammation? Well, with anti-inflammatories. I mean, if you ask a general question, you're going to get a very general answer, and treating the cause. Treat the cause of the inflammation and anti-inflammatories. Let me see if there's any other pressing questions here. Vagus nerve dysfunction. Yes, there's autonomic nervous system tests you can run. Nothing specific for the vagus nerve, but you can look at the parasympathetic versus the sympathetic. There's several different tests that you can do. One is the tilt test, everybody knows. One is the QSART test. There's also a sweat test because sweating is autonomic. And vagus nerve by itself, well, I guess you could look at the voice and the vocal cords, but that's really part of the vagus nervous system, not the entire nerve. And you can also study it with ultrasound and or MRI.
There are studies that I just want to remind. Oops, sorry about that. We do have access at the Long COVID Association. We've been able to have access to a software in development that looks at your forced cough vocalization. They've done studies and research to analyze your health and wellness based on your vocal cords. The group has donated the use of their
Yeah, that's very
software for.
interesting. It listens to your voice.
Yeah, it can tell the changes, and they're able to tell now between if you have RSV infection, pneumonia, tuberculosis, changes from smoking, if you your COVID.
Mira, let me just
Sure, go
finish
ahead.
this one thought here from Melinda,
Okay.
and we'll stop there. Okay.
Okay.
She's asking about the QSAR test and if it's fine. If everything else is fine, but the QSAR test is positive. So the autonomic nervous system is segmental. Okay, that means it works in pieces. One piece can work without the other because there's little ganglia or little relays or little brains along the autonomic nervous system that let it work on its own. That's why it's automatic, automatic, and it can run things even if cut off from the rest of the system. Our other nerves cannot do that, but the autonomic nervous system can. So flushing is an autonomic function, sweating is an autonomic function, and sexual ability is part of the autonomic nervous system. Production of tears, generation of saliva, the beating of your heart rate, and your blood pressure are all autonomic. Okay, so you can use these kind of clues to see what it's doing, but there's no direct way to check the autonomic nervous system. And it's very common to see segments. One part is working fine, another part is completely dysfunctional. And that's also why we're seeing a lot of different symptoms with POTS, for instance. Depending on how far the dysfunction goes, there's different symptoms. And digestion is a really big feature of the autonomic nervous system. And that's everything from swallowing, digestion, that is sending it through. When is the pancreas supposed to release its enzymes? When is the liver supposed to send the bile? All that's coordinated through the autonomic nervous system. All right, sorry, Amira. I just wanted to finish that before I gotta go.
Okay. Next time we have to address muscle pain and inflammation in the hips and knees, large joints, many months
Well,
after
I mean, look,
COVID.
I've addressed that a few times before. It's a general
Yeah.
myalgia and arthralgia that you
Mhm.
see with most viral infections and some post-viral infection or post-viral conditions or syndromes. Um, some of it could be inflammatory, but most of it is not.
Okay.
It's just a myalgia from having a virus. All
Can
right.
any of it be autoimmune
Yes, it can be.
partly?
Yes, it can be. That's why some people get a positive ANA or positive rheumatoid factor or positive lupus antibodies, but that's not the majority, okay, of people with long COVID and joint pain, okay? I think a lot of it is going to be neuropathic, and I think it's just general myalgia and arthralgia, not autoimmune. Not to say it can happen and does happen. It's just not the majority of people with joint pain. Okay.
So it changed with me, went from ANA positive to ANA negative. So I
Right.
saw it
I mean,
change over time.
it's not really related though to the autoimmune. Can you develop autoimmune with long COVID? Absolutely. But I just don't think that that's the majority reason for the joint pain in long COVID. Okay. And with that, I think we'll wind
Save
it
it
up.
for
Okay.
later. Thank you, everyone, for being here. I'm Amira Saleh. This is Dr. Robert Groysman. Please like, share this video, follow us on social media, and join us next time in 2 weeks. We'll be
10
here
o'clock.
again. Yes, 10 a.m. Central Standard, 11 a.m. Eastern. And just to confirm the date, that'll be February 18th. So if you registered in the Zoom, you can use the same link. We'll have an updated link for the restream, and you can join us that way as well. Please share this with everyone who you care about who needs help about long COVID. And you can visit Dr. Groysman at covidinstitute.org. And you can find me on longcovidassociation.org or longcovidassociation.com. I want to thank you and know that there is hope out there. There are doctors who understand the condition and there are treatments. So, with that,
I'm going
good.
to say one more thing.
Yes.
Yes, this stream is recorded. It's going to be available on my YouTube channel. It's available in the Facebook group. It's going to be recording available for review later. Okay. All right.
Thank you, everyone.